I'm going to briefly go through timing of ADT and chemotherapy. These are my conflicts. And this is a list of the currently available castrate-resistant prostate cancer treatments, all of which started at the very end of the spectrum. It's been moved forward more and more. And if earlier is better, then when we look at this, could these agents be applied to hormone-sensitive prostate cancer? And indeed, they have been. We've certainly seen the Latitude study, we've seen the Chartered study, we've seen Stampede. But which agents and when is the question? So I'm going to talk about Chartered. I'm going to compare it to the GETUG-AFU, which was essentially a negative study, and try and tease out some of the differences between it, and then ask the question, who should really receive docetaxel and the safety and consideration? So we all know this data. It was taken on 780 patients. It really shook the urology community when chemohormonal therapy did turn out to be significantly better for metastatic prostate cancer, hormone sensitive, I should say. And the group that did best were the people, well, this is the overall data, and it showed a dramatic difference, 57.6 months versus 44 months. So it's highly statistically significant. And when we looked at the extent of disease, the benefits were all seen in the high volume prostate cancer patients. Basically, there was nothing to really see in the low volume disease, which brings into the question, how do we group these patients into high and low volume? But looking at Chartered 4 years on, we still find the same changes. We still find the same benefits. We once again see that the benefits are basically restricted to high volume disease. Low volume disease showed no evidence of improved survival, and that's published in 2018. Then Stampede came along, which reinforced the results of Chartered. And Stampede is a really remarkable trial. It's probably the best trial ever invented because they have the same control group across 7 different treatment paradigms. And once again, everybody's had a sigh of relief, really, when it did confirm the findings in Chartered, because the GETUG-15 study did not confirm the findings in Chartered. What the GETUG-15 study showed was that there was a highly significant biochemical progression-free survival, but no overall survival. So that led myself and a couple of other guys to take a look at some of the differences between the GETUG-15 and the Chartered data. Number one, when you look at it, you can see there was half the number of patients in the GETUG study. There was the docetaxel given, the amounts were different. Gleason 8 disease, 56% versus 68%. PSA, considerably higher in the Chartered data. High volume disease, only 21.6% of patients in the GETUG-15 as opposed to 65% in the Chartered. There was also the discontinuations for early toxicity and treatment deaths, which were significantly different. And one of the other things to remember is that GETUG-15 came out a year and a half before Chartered. And when patients failed on the GETUG-15, they did not have the availability of enzalutamide or abiraterone. So that's a substantial difference, which may explain some of the difference. So to put it all together, study size, statistical power were different, prognosis and staging definitions in disease were different, and toxicity and deaths and early discontinuations were different. And that's what I want to focus on, is the toxicity. And to make this, to move it up a bit, we also looked at the TAX327 data, which was the data that got docetaxel approved in castrate-resistant prostate cancer. And we looked at the febrile neutropenia, and for some reason, the GETUG-15 had a lot more of it. And the key conclusion is that it's tough to interpret this toxicity data with incomplete information, but there is a sense that docetaxel may surprisingly be more toxic in hormone-sensitive prostate cancer. Well, it's no surprise at all, because in 2010, a guy called Frankie et al. And his pals examined the relative clearance of docetaxel in 10 non-castrate patients and 20 castrated patients with prostate cancer. Docetaxel pharmacokinetics were significantly altered in the castrated men, with an approximately 100% increase in docetaxel clearance. So if you are castrate, you don't get as much docetaxel in. And this is just a graphic of that, but a 50% decrease in docetaxel clearance is associated with an over 430% increase in the odds of grade 3 to 4 neutropenia. That was a highly significant difference. So what are the implications of these differences? Well, it may explain some of the greater hematologic toxicity, but also survival benefit observed in the castration-sensitive patients compared to castration-resistant may also be a factor. Why was there greater hematologic toxicity in the GETUG-15 versus the Charter data? Well, the patients in the GETUG-15 received their chemotherapy, 47% of them, 2 weeks after going on ADT. The ADT used was an agonist. And everybody in this room knows it takes 4 weeks on average to render a patient castrate on an agonist. And Chartered initiated their chemotherapy over a month after the patients had been on ADT. So that would explain some of the differences. So if toxicity is greater in this group, however, well, you might be reasonable to say, well, maybe the efficacy is also. So we needed a trial. Was there a rationale for this trial? Does one exist? Well, yes, it does. This is data showing in vitro studies of androgen deprivation of androgen-dependent prostate cancer cell lines showed increased sensitivity to taxane-mediated cell death in response to androgen stimulation. In a separate LINCAP trial, where they had LINCAP-bearing immunodeficient mice, tumor volume and tumor apoptosis were measured in response to castration alone, docetaxel alone, both interventions administered concurrently, and both administered in different sequences. And guess what? Docetaxel prior to castration led to the longest delay in tumor growth. In breast cancer, hormone receptor positive breast adenocarcinoma is also responsive to hormone manipulation and chemotherapy, but as opposed to prostate cancer, the established paradigm in breast cancer is administering cytotoxic chemotherapy independent from hormone manipulation, and you can see a trial there that I'm not going to go through. There are human trials in prostate cancer. Maha Hussein treated 39 men with normal testosterone and rising PSA post-prostatectomy or radiation with up to 6 cycles of docetaxel at the dose shown there every 3 weeks. Chemotherapy was followed by total androgen blockade, and the serum PSAs decreased by 50% in 48.5% of the patients on docetaxel alone before they got the ADT, and 75% in 20 of the patients with docetaxel alone. I don't need to come back there, sorry. Oh, can I go back up one, please? Can you move me back one? Thank you. The majority of these patients did have PSA progression after stopping ADT, but 5 or 15% of the 33 patients had an undetectable PSA at a median of 18.9 months after stopping ADT. 7 of the men in this study had METs, and 3 of those were among those patients who saw the maximum benefit. This is our trial. It's a phase 2 study of docetaxel before medical castration with degarelix in patients with newly diagnosed metastatic carcinoma. We're enrolling 50 patients. Primary endpoints, proportion of men who maintain a PSA of less than 0.2 nanograms per ml for 40 weeks on study with 7 months of ADT after being treated. Additional endpoints are toxicity, PSA response to docetaxel alone, time to development of castration resistance, overall survival, and we will use correlating genomics with response. The study design is single arm. There are newly diagnosed metastatic hormone-sensitive prostate cancer patients are given 4 cycles of docetaxel without castration, followed by 2 cycles of docetaxel concurrent with degarelix, which is run out for a year. We're enrolling at MUSC, at the VA in Charleston, and we recently opened it at the University of Maryland. Goal is to enroll all the patients in 24 months. Accrual's ongoing. So far, we have 27 patients in total. 74% of the patients have high volume disease using the Charter definition, and the nice thing is 60% are Caucasian, but 40% are African American. So my last slide deals with the issues. Is it a good idea to use these agents up front? It would certainly seem to be so. I think that high volume disease, maybe docetaxel is the way to go. Low volume disease, I don't believe so. I think for that, we have the abiraterone, we'll probably have enzalutamide, etc. The other question is, will we negate the benefit of subsequent therapies? Will we see earlier resistance? Or perhaps we will delay the need for the introduction of subsequent therapies. We have to wait and see. Remember, docetaxel response rate was lower and survival much less when you give it to castrate-resistant prostate cancers. It's also much better tolerated in fitter, younger patients, as these patients will be who are presenting. They haven't been treated half to death. Should it be reserved for high-volume metastatic disease, this regimen? I believe it should. And cost must be a factor for all these strategies. Thanks for listening.